Hello and welcome to the module on the clinical curriculum and case study explanations. As I alluded to at the end of the last module, this one contains a bit more information because clinical rotation is unique in that in addition to your weekly logs and your midterm and final evaluations, you'll also be completing a mini case study or topic presentation and a major case study. If you look on page 26 of your student manual, you'll again find that bulleted list of possible learning experiences. And then when you click on Appendix C, that's where you will find the clinical curriculum. We will be going over the clinical curriculum line by line at the end of this module, so you won't miss it. But I would like to first take some time to explain the case studies that you will present during your clinical rotation, and those can be found on page 28. So during your clinical rotation, you will be required to do both a mini and a major case study. So the mini case study should be presented at about the halfway point of your primary clinical rotation or that clinical rotation you're spending the most time at. So I think most of you will spend about 8 weeks at one clinical site. That would be considered your primary clinical rotation. This mini case study is a presentation that will last about 20 minutes in length, plus some additional time for questions at the end. And so the purpose of this mini case study presentation is really just to showcase you can navigate the facility's electronic medical record and that you can demonstrate your knowledge of the nutrition care process. So it is very likely that you will have only completed one assessment on this patient that you choose for your mini case study. You don't have to do a whole lot of follow-up on them. It's a very short presentation. And in my experience as a preceptor, this mini case study tends to be a bit more casual, usually can just be presented in the office with a handout versus a fancy presentation. And again, it only takes about 20 minutes, so you want to be careful that you're not selecting a patient that is too overly complicated, that you wouldn't be able to explain your nutrition care plan in that 20-minute time frame. Now, if you and your preceptor both agree that you are grasping the basic concepts of navigating the electronic medical record and the nutrition care process, you may alternatively wish to do a topic presentation. I know it's not described here in the manual, but this is an option that your preceptors are aware of also. So this topic presentation would again be a 20-minute, more casual presentation, but instead of presenting on a patient, you would present on a topic that the staff in the dietitian's office is interested in. So for example, when I was precepting, we came across a patient that had a chyle leak, and not many of the dietitians knew the nutritional management strategies for that disease. So instead of doing the mini case, we asked that intern to please present a 20-minute presentation on chyle leaks, just giving us background, what the latest MNT is, and giving us recommendations for how we could treat those patients should we run into them in the future. So if the topic presentation interests you, certainly be on the lookout for some of those interesting, more rare nutrition-related issues. Always make sure it's nutrition-related. And that would make a good topic presentation. And then just make sure that you and your preceptor are on the same page in terms of doing the topic presentation in place of the mini case study. So for the major case study, this presentation is going to be a little bit longer and more formal of a presentation. This major case study should be about 50 minutes in length, plus should allow time for questions at the end. And this will also be presented as part of your final evaluation. What that means is that Dr. Schumacher or myself will either be doing a Zoom video conference to watch your presentation and then do your final evaluation with you and your preceptor, or we might be having you record that final presentation and uploading it into ReggieNet, and then we will still do a phone call for your final evaluation. Again, for this major case study, this should be a bit more complex of a patient where you have to use more critical thinking skills, maybe prioritize between several different nutrition diagnoses. And you should definitely plan to present on the pathophysiology of the disease, a little bit more of the current research on the latest MNT recommendations for your patient's condition, etc. Goes into a bit more detail. With your major case study, you might start seeing them as early as like the week of your midterm, so almost halfway through your rotation, because the intention is to have you do not only that original assessment, but also aim to do at least a couple of follow-ups and reassessments with that patient before they are discharged. So we want you to have a lot of interaction with them so that you have a good amount of material to present on. Again, I would encourage you to closely go back and review the guidelines for individual case studies here on page 28 of your handbook. But also, we have provided a guideline of items to consider when planning for your mini and major case study. So to assist in planning for those case studies, you'll want to use this outline on page 29. And I think it will be very helpful for you in planning for your presentation. After you present your case studies, it is definitely important to get feedback from your audience. So this feedback is not only going to allow you to see what improvements you can make for future presentations, but it's also going to reassure you what you are doing well. So on page 31, you've been provided with an evaluation of the case study presentation. This is also located on ReggieNet, which I will show you in another module. But you want to be sure to print off copies of these and provide them to each of your audience members before your presentation so they can fill it out, get it back to you. You will ultimately be scanning these into ReggieNet and providing them to me so that we can see how your presentation went. So just a couple of important reminders and recommendations regarding the case study that I would like to summarize. You should always get approval from your supervising dietitian before selecting a patient that's going to be your case study. So this is important for a couple of reasons. The preceptor is going to want to help make sure that the patient that you chose isn't too complex for a mini case study or isn't too simple for a major case study. By also getting that patient approved, it's going to help you communicate to all of the dietitians that any follow-up, especially for your major case study, can be conducted by you as the intern, so that you've personally done that original assessment and any additional follow-up so you can present on it in your presentation. I would really encourage you to plan a meeting time with your primary preceptor to review this outline on page 29 before you present. That way the preceptor can make sure you are on the right page, highlighting the correct information, and if there's anything that they personally would like you to emphasize on or delve into a little bit more, they can help guide you so that when it comes to presentation day, you can feel very confident. I would really encourage you to be prepared for these case studies. Make sure that you give yourself some additional time on especially your major case study to come in that day, get your case studies printed out, get your evaluation forms printed out, have your presentation ready, test equipment to make sure that technology isn't going to fail you right at the time of your evaluation. And then I would encourage you also to invite any other medical professionals that may have been involved in that patient's care to your major case study. So, for example, if the patient that you're presenting for your major case study had swallowing issues, and that's a big part of what you'll be presenting on, it might be valuable to have the speech therapist or the speech language pathologist come to your presentation because they could learn from your presentation as well. If you have any questions about the case study presentations, please be sure to email us and we will address them in the live Q&A, and we of course are always available throughout the rotation if questions come up. But definitely go back and review this. The next thing we will be doing is going through the clinical curriculum line by line. So I've jumped back to page 26. This again is that list of bulleted bulleted experiences, that you can then relate to the different competencies. And then if you click the hyperlink to Appendix C, that's where you will find the clinical curriculum set up the same way as the food service and the community. So for 1.2, applying evidence-based guidelines, systematic reviews, and scientific literature, you will have ample opportunity to meet this competency in the development of your mini and major case study presentations, as well as your daily interaction and management of your patient workload. CRDN 1.4 is to evaluate emerging research for application in nutrition and dietetics. Again, if you run into a disease state that you're not familiar with, we would certainly encourage you to do a little digging, do a little research within the time frame of your workday and evaluate that emerging research. CRDN 1.6 is to incorporate critical thinking skills into overall practice. I can assure you in clinical, you are going to have every opportunity day in and day out to use your critical thinking skills. CRDN 2.1 is that long one, practicing in compliance with current federal regulations and state statutes, the scope of nutrition and dietetics practice, and the code of ethics for nutrition and dietetics. So again, doing hospital orientation, becoming familiar with the nutrition department's screening, assessment, reassessment policies, how they provide education, being sure to provide or to abide by all of those organizational policies as well as the policies of ISU's internship, and then abiding by HIPAA training in your daily activities, making sure that your patient worksheets are turned over when you're walking in the hallway, etc. CRDN 2.2 is to demonstrate professional writing in preparing professional communications. So as in community, this could be in a newsletter for the hospital, writing up something for a professional journal, but also just in your daily documentation of patient notes and in the electronic medical record. You always want to be professional. CRDN 2.3 is demonstrating active participation, teamwork, and contributions in a team setting. So if you and the dietitian you're working with are done for the day, maybe it's checking in and seeing if you can help another dietitian, attending and participating in any of the professional meetings that your preceptor might go to. For example, there might be interdisciplinary care rounds that you can attend and participate in. Maybe you can go to a stroke team meeting or a critical care team meeting and provide some feedback so that you're doing some assistance and helping instead of just observing. CRDN 2.4 is to function as a member of the interprofessional team. So again, attending those interdisciplinary conferences, rounding on patients, presenting that nutrition care portion of a team conference. CRDN 2.5 is to assign duties to diet techs or other support personnel as possible. While not every clinical facility is going to have a diet tech, you may, for this competency, communicate with the nurse, communicate with physicians, CNAs, in order to get the information you need to do your patient assessment. You may defer like a supplement check or a PO intake check to one of the diet techs, or again, asking the CNA, just working as a team member with other support personnel. CRDN 2.6 is referring clients and patients to other professionals and services when the needs are beyond our scope of practice. So again, if you have a patient who's having swallowing difficulties, maybe you want to refer them to a speech pathologist. If you have a patient who has very uncontrolled diabetes, it might be referring them to a diabetes management program in the outpatient setting. Definitely meet with your preceptor and have a good understanding of what services are available in their community that you could possibly make referrals for. CRDN 2.7 is applying leadership skills to achieve the desired outcomes. Especially in clinical, you really need to advocate for your own experience. So I always used to tell interns, if you hear a nurse saying they're going to go drop an NG feeding tube for a patient, raise your hand, track that nurse down, ask your preceptor to get you in there so that you can observe. Really take control of your experiences and be a leader so that you can get the most out of that clinical rotation. CRDN 2.8 is demonstrating negotiation skills. This can be achieved when completing client educations, conducting patient interviews, or talking with physicians about changing a diet, recommending an appetite stimulant or a supplement, etc. CRDN 2.10 is demonstrating professional attributes in all areas of practice. This is in your day-to-day emails, being punctual, your daily dress, your interaction with physicians, nurses, CNAs, the janitor, everyone. CRDN 2.12 is performing self-assessment and developing goals for self-improvement throughout the program. So again, you'll have that opportunity during the midterm evaluation to do a self-assessment, which we'll talk about in another module, but also providing those evaluation forms for your presentation, reviewing them, and making improvements for your next presentation. CRDN 3.1 is performing the nutrition care process and using standardized nutrition language for individuals, groups, and populations of differing ages, health status, and in a variety of settings. So as long as the site that you are working at uses the nutrition care process or ADIME for assessing their patients, you will likely meet this competency day in and day out. So this can be accomplished by performing nutrition assessments, analyzing assessment data, writing PES statements, and so on. CRDN 3.2, is conducting nutrition-focused physical exams. While not every site is likely doing nutrition-focused physical exams, if you have the opportunity to watch some training videos or observe your preceptor doing exams, getting that hands-on practice doing nutrition-focused physical exams, that would be great. If the one or two sites that you plan to go to for clinical don't conduct physical exams at this time, we will be focusing on physical exams in one of our modules in FCS 402. So don't worry if you don't achieve those minimum quartiles for 3.2. CRDN 3.3 is demonstrating effective communication skills for clinical and customer service. This again could be disseminating a nutrition-related issue through the contribution in a professional newsletter, a press release, a poster. I would suggest if the hospital has some type of internal newsletter that you could write an article for on a health topic that could be published, that's not only something that would meet these competencies, but also something that you could save and put in your professional portfolio. CRDN 3.6 is using effective education and counseling skills to facilitate behavior change. So this could be accomplished through assessing the learning needs of the patient, identifying those desired outcomes, and developing and implementing a plan for nutrition counseling. 3.8 is to deliver respectful, science-based answers to consumer questions concerning emerging trends. You are going to get a lot of questions about the latest and greatest nutrition fads, and so you always want to be respectful and deliver those science-based answers by utilizing the Academy's Evidence Analysis Library, ASPEN, the Nutrition Care Manual, etc. CRDN 4.4 is applying current nutrition informatics to develop, store, retrieve, and disseminate information and data. So this could be as simple as using the electronic medical record, using PowerPoint and Word to develop your case study presentations, but also if there's any data that your preceptor pulls out of the electronic medical record and analyzes for quality improvement, sit down and talk to them about how they use that data and see if you could make any suggestions for what that data might mean or improvements that they can make based on what you have observed while you've been working in their facility. CRDN 4.9 is to explain the process of coding and billing for nutrition and dietetic services to obtain reimbursement from the public or private payers, fee-for-service, and value-based payment systems. This is not evaluated during clinical because we will talk about it in FCS 402. However, if you do have the opportunity to meet with maybe the case managers in your clinical site or those employees who are responsible for doing the coding and billing, you might just be able to get a better idea of what services are reimbursable for nutrition and dietetics and which ones aren't. And then finally, CRDN 4.10 is to analyze risk in nutrition and dietetics practice. So this could be talking with your preceptor or documenting the risk of initiating versus not initiating nutrition support. Maybe it's justifying your case to the physician on why you don't want to initiate a feeding tube in a patient who has advanced dementia. Associating malnutrition with hospital outcomes. So again, if a patient comes into the hospital and they are considered malnourished, what risk does that pose on hospital outcomes such as development of wounds, surgical site infections, length of stay, etc. So that concludes Appendix C and also concludes the clinical competencies and also is the last list of competencies that I need to read to you for the competency modules. In the next module, we will be discussing how exactly you're going to use all of these competencies to develop your weekly logs and your evaluations.